professionals, Professor Kameswara sir, Dr. Praveen, and dear friends. So today's topic will be on young hypertensive patient with mild LVH. So how to discuss this patient, how to treat a good and up-to-date treatment for our population. See, the young hypertensives are very common in our population, and most of these young hypertensives they also associated with LVH and other target organ damages. See, this is in hypertension in the young adults. The prevalence of the hypertension in the young Indians is about 10 to 30%. Top 3 risk factors in Indian patients were smoking, mental stress, and obesity. See, these are the lifestyle disorders. Smoking will increase all the complications of the hypertension, and the stress will increase the counter-regulatory hormones that causes a lot of the oxidative stress, and obesity will cause a lot of the complications in hypertension and diabetic individuals in causing vascular diseases, in causing renal problems, in causing peripheral vascular diseases, and also leads to a lot of the morbidity and the mortality. And the two important things are the increased heart rate and increased systolic blood pressure. These are the markers of the sympathetic overdrive. So when the fellow is presented with hypertension and a heart rate of say 110 or 100 plus or the 90 plus and the systolic blood pressure 140 plus, so always think of some sympathetic overdrive in such individuals. See, this is an index case, a 45-year-old gentleman presented to the clinic for an hypertension review. He has been seen in the clinic 1 month previously and had 2 high blood pressure readings. At this time, he was advised to lose the weight as his BMI was 35 and also to reduce his salt intake. And the average blood pressure at home, the daytime is between 150 to 160 systolic, and the diastolic is about 85 to 95. And he complains of shortness of the breath, chest pain, and palpitations. And currently he mentions his weight has reduced with a BMI of 33, and he has reduced his salt intake also. And the today's BP is 162 by 92. He is currently not on any medication. So such cases are very common in our daily practice, that at a 45-year-old male, obesity and high blood pressures, the systolic more than 140, diastolic more than 90, with the symptoms of the chest pain, palpitations, and breathlessness are very common in our practice. And the BP is 162 by 92. So definitely he is having the hypertension, obesity, and also symptomatic. And coming to the family history, he is not aware of his diabetes status. So he is not a diabetic at this juncture. But mother had heart attack in her 70s, was a long-standing diabetic patient. So mother had diabetes and ischemic heart disease. And he mentions one of his aunt also had kidney issues that was linked to her diabetes. Which was not well controlled. See, aunt had diabetes and also the renal failure, and he would like to avoid the treatment where possible. So he doesn't want any management. Should he be investigated for the secondary hypertension? So what are the signs that should be examined or watched for that? See, in this population, as he is having the hypertension, so usually we think that it's a primary hypertension, but always we should also look for the secondary hypertension in such individuals. And these are some causes of the secondary hypertension as far as the age is concerned. See, up to the 20 years, aortic syndromes or the coarctation of the aorta, or the renovascular hypertension like fibromuscular dysplasia, or the monogenic disorder, some genetical disorders, some pheochromocytomas. So these are the very common in this young age group. And between 20 and the 40 years of the age group, so the renal parenchymal disease or the renovascular hypertension like fibromuscular dysplasia, a monogenic hypertension, so genetic hypertension, or endocrine hypertension like pheochromocytoma, paraganglioma, primary aldosteronisms. So these are the common. Once the age is beyond the 60 years or 65 years, so as atherosclerosis, it is mostly because of the renovascular hypertension, because of the renal artery stenosis, or the renal parenchymal disease like a CKD. See the investigations, if you, this patient HbA1c is 8.1%. So that means is a diabetic. So asymptomatic diabetic, already had an hypertension and the obesity, and father had diabetes, mother had diabetes. Now he also has a diabetic, diagnosed with HbA1c 8.1%. And urinary albumin is 100 milligrams per day. So that means he is also having albuminuria and triglycerides. So he is having dyslipidemia, and LVH is on mild LVH observed upon the echo, and the heart rate is 95. So uh, asymptomatically he is also having the, along with the hypertension, obesity, he is having the diabetes was first time diagnosed, and albuminuria is diagnosed as a renal nephropathy, and is a dyslipidemic, and also LVH. So echo can be diagnosed by the three ways. One is by your ECG, and the second one is the echo, and third one is the MRI of the heart. But most usually we do the ECG and also the echo. Now echo is available everywhere. And echo, there are the four important points to say that this fellow is in the LVH. So global increased wall thickness, normal LV cavity size, increased left ventricular mass, and increased relative wall thickness. So these four things will tell you this fellow is having a LVH. See, the LVH is an important finding and very easy to diagnose LVH either by the ECG or the echo. And LVH is an independent risk factor to have an ischemic heart disease, independent risk factor to cause the heart failure also. So these are the guidelines to say that how to diagnose the LVH. So the ECG sensitivity is 2 plus, specificity is 3 plus, whereas the echo is a more. Reproducibility, both are reproducible, but more so in the ECG because it is available. Prognostic significance is also good. Availability, and now the echo and ECG are available everywhere, and cost, echo cost a little higher when compared to the ECG. But definitely, even though the ECG shows a normal and echo picks up the early LVH. So both the ECG and the echo are very much useful to diagnose the LVH and also to assess the amount of the LVH, left ventricular mass, or etc. So what percentage of the young hypertensive diabetic patients who present with a mild LVH or elevated urine albumin in our practice? See, very good number of the people are there because both the LVH and urine albuminuria is an asymptomatic conditions. See, hypertension with diabetes. So it's a deadly duo. So in all the hypertension with the diabetes, we have to assess for the end organ damage. If you see the second half of the picture here, end organ damage present in hypertension 36.2%, in diabetes about 42.5%, both the hypertension and the diabetes about the 45%. So in all the Indian population, so all the hypertension should be screened for the diabetes, all the diabetes should be screened for the hypertension because both are asymptomatic and a deadly duo, very common with common environmental factors. And when the both are the present, so there is always a chance of having end organ damage. So this is a fundus is also very important to look for it for any exudates or hemorrhages or, new vessel formations, etc. So currently all hypertensive diabetic patients refer for the fundoscopy. So definitely, so there are all the different markers of your hypertension mediated organ damage: LVH by ECG, LVH by echo, LVH by MRI, and also GFRs, urinary albumin creatinine ratio, that is much more useful, carotid intima-media thickness, ankle brachial index. So all these tells you whether this fellow is having a vascular risk or not. So what are the mandatory investigations for a long-standing diabetic hypertensive patients? So what should be the further course of the treatment in this patient? So a lot of the investigations are needed. And coming to the management in this patient, lifestyle management and pharmacological management. All the diabetic and hypertensive patients, lifestyle measures are very, very important. So walking or maintaining the normal body weight and avoiding the sedentary behavior, and then the aerobic exercises, some resistance exercises, so some isometric exercises, and then more fruits, and then the more egg whites or the fish, and then the less salt, definitely more potassium because both are antagonistic, and the sugar has to be limited, carbohydrate amount has to be limited, mostly the simple sugars, more fiber, so moderation of the alcohol, and then the moderation of the tea or the coffees, And then the body and the mind sleep at least 7 to 8 hours of the sleep, meditation, mindfulness, and then listening to the music, and avoidance of the smoking in any form is always there. Dangerous. Avoidance of the smoking is good. And then the pollution free exposures. So these are the very, very important lifestyle measures. Very easy to say, but very, very difficult to practice. But these are very, very important for all the diabetic and hypertensive measures to keep their blood pressure and blood sugars under control. So what should be your choice of the therapies? Is it ACE or ARBs, or calcium channel blockers, or the diuretics, or any role of the beta blockers here? See, this is the, we all know that in the step one, now the combination therapy is the rule for all the hypertensive population, because we see the hypertension at the stage of second stage only. Second stage means 160 systolic and the diastolic more than the 100. When you see a hypertension between 140/90 or 150/90, so you can try with the lifestyle measures and with a single drug. But 80 to 95% of the patients we see in the stage 2 and the stage 3 hypertension, where a combination drug therapy is always needed. In this combination, the step one, we use ACE inhibitors or ARB plus either a diuretic or a calcium channel blocker. In the step two, we use the ACE or ARB plus calcium channel blocker plus the diuretic. And if the when the diabetes is not, when the hypertension is not under control, and definitely we need the fourth drug, that could be a vasodilatory beta blocker or a spironolactone or etc. And we consider that condition as a resistant hypertension. And of course, beta blockers can be used as a monotherapy or as any step at the combination therapy, because the beta blockers are the very much indicated as a compelling indication in the ischemic heart disease, in the tachyarrhythmias, and in the management of the heart failure, etc. CAS preferred are the ARB. So within what duration are the beneficial effects on the organ damage seen with the initiation of ACE or ARBs? See, there are the different trials, head-to-head trials. If you see the cardiovascular mortality, both are the same. ACE inhibitors, ARBs are the same. And when you see the myocardial infarction, ACE are more favorable when compared to the ARBs. In the management of the stroke, ARBs are much more superior. And end-stage renal disease, ARBs are much more superior. So as far as the ACE or ARBs, ACE are having a more useful in the presence of the myocardial infarction, whereas in the CVAs or in the renal failures or in the to reduce the overall cardiovascular mortality, I think ARBs are much superior to the ARBs, ACE inhibitors. And coming to the calcium channel blockers, they are divided into the 4 generations, but usually we use amlodipine and the cilindipine. The amlodipine is the 3rd generation and cilindipine is the 4th generation, and first generations are the nifedipine. Still we use the nifedipine in the CKD population when the creatinine is 5 or the 6, when the blood pressures are very high. We use nifedipine 20 milligrams of TID or the BD, and most useful calcium channel blockers are amlodipine and the cilindipine in our daily practice. So what benefits would be the novel CCB, cilindipine, have to offer in this patient? See, this is the bioequivalence with the Selacar, the Indian drug compared to the Japanese drug innovator. So both are the same. So summarizing the discussion, increasing the prevalence of the hypertension seen in the young Indians, commonly comorbidity is the diabetes. And of course, most of the young Indians with hypertension and diabetes, they are also the smokers, they are the obese, and they are with a strong family history for the cardiovascular diseases. So these are the very, very important group. One should be very careful in dealing these population. Hypertension along with the diabetes worsens the cardiovascular outcomes and deteriorates the quality of the life. All the complications of the diabetes will be multiplied in the presence of the hypertension. Guidelines focus on measures for early detection of the hypertension mediated organ damage. A combination therapy is always recommended. Most guidelines, already I told you, your ACE or ARB plus calcium channel blocker are the diuretics. That is the reason we are having the triple drug combination of the Indian population, mostly ARB plus calcium channel blocker and diuretic. Lifestyle modifications have is a very, very important role to play as an adjuvant to the pharmacological management. And pharmacological management should be focused on the molecules that not only reduce the BP numbers, but also have a organoprotective benefits. So cardioprotection and the renoprotection. So for your cardioprotection and the renoprotection, your ACE inhibitors are very superior, and your calcium channel blockers are useful, and your chlorthalidone is useful as a good diuretic, and your bisoprolol or your carvedilol, they are useful as a vasodilator beta blockers. And even when the blood pressure is not under good control with all these drugs, then you can add the central acting drug like the arcamine, or you can add the loop diuretics like torsemide or the furosemide when the GFR is less than the 30. So thank you very much for your patient hearing. Thanks one and all.